Good day, everybody. Good afternoon, good morning, good evening. I want to welcome everybody to today's panel discussion on the implications of what's known as the most favored nation policy for pharmaceutical medicines and biopharmaceuticals. The United States White House and the Centers for Medicare and Medicaid Services proposed most favored nation MFN pricing as an approach for a more domestic lever, and it's been a shockwave globally with regards to what's going to happen to pricing. And while the details are coming to surface, the current line of thinking is that the U.S. would pay the same price as the lowest of a peer number of nations, based on per capita GDP or on another nation's pricing. And when we've looked at this at Indegene, what we've found is the potential for that is monumental, with reductions of almost 60% to 90% of revenues as a catastrophic hit. Following that, in July 31st, President Trump sent a letter to 17 pharmaceutical manufacturers and asked for the following actions by the end of September, which is now just 8 days away. Provide most favored nation for all drugs within the manufactured portfolio to all Medicaid patients. Enter into a contract with the U.S. to provide most favored nations for newly launched drugs to Medicare, Medicaid, and commercial payers, and enter into a contract with the U.S. where manufacturer agrees to repatriate increased revenue earned abroad to lowering prices for U.S. payers, patients, and taxpayers, providing the MFN for all drugs within the manufacturer portfolio to everybody in Medicaid, future products in commercial, and then moving forward, paying back some of that to taxpayers. So ultimately, what may begin as a U.S. policy experiment or as a policy in general may inevitably reverberate throughout Europe and the rest of the world, challenging payer strategies, budget frameworks, healthcare infrastructures, and cross-border reference pricing. So when we thought about this, we thought about, let's not just take a myopic view and look at it from a U.S.-only perspective, but let's bring in senior people from the United States, the UK, and Germany to dissect how most favored nations are viewed in their countries. And so we brought those payer voices here to see how they see them possibly establishing more and new norms, disrupting established norms, and accelerating transatlantic shifts in access and affordability. Nekshan, Dalal, and myself will be moderating this group, but I wanted to make sure that you got a chance to meet everybody here. So I'd like for each of them to introduce themselves, tell a little bit about their background and their countries of interest, and then we'll go from there with some questions. But let me hand it off to James to do the round of introductions.
Hello, my name's James Mahan. I'm an economist who's provided health economics advice and consultancy to the private and public sector for 25 years. For about the past 15 years, I've worked very closely with the University of Liverpool, reviewing and producing submissions for NICE to help with technology appraisal and pricing. And I also work very closely with the University of York, providing direct consultancy to the NHS and private sector in producing submissions, amongst other things.
Harold?
My name is Harald Herholz. I'm a physician by background. I'm based here in Frankfurt, Germany, and I'm the head of the department for drug reimbursement of a big German payer organization. And my organization is a voting member of the GBA in Berlin, which is a federal joint committee, and that's the central place where all new drugs get assessed.
And last but not least, Jeff?
Hello, Jeff Dunn. I am a pharmacist by training. Like James, I've been in my role or my career for about 25 years. I started out at an IDN and a health plan, and then from there, spent time at a large employer coalition and have worked for 3 different PBMs in my life, 1 traditional and 2 transparent pass-throughs. And so I've been able to see different perspectives from the different types of organizations. But I've had formulary, oversight, strategy, rebate, clinical program responsibilities in my career.
Great. Thanks, guys. And thanks for being here again. Let's start with, we're looking at a world where the U.S. has a potential to attach drug prices to ex-U.S. or European levels. And I'd like for you first to give me your initial thoughts on such a plan and what you think the implications are for your health system. And Jeff, let me start with you with regards to, from the U.S. perspective, you are brought in as a PBM to negotiate on behalf of the government for rebate streams as a PDP, as well as for managed Medicaid and other services. What do you see if something like most favored nations comes to be?
Well, we're obviously watching it with. I have been doing this for so long. I'm a little cynical that we're going to see much impact in this country. I think more of the impact is going to be in other countries. Because I know what I would do if I'm a pharmaceutical company, and the majority of my revenue is driven by the United States market. I would just say healthcare in this country is extremely complicated. The analogy I would use is it's kind of like a balloon. And we've seen this. If you kind of poke it and you address one thing, it has 10 to 15 other consequences. Many of those are unintended. And unfortunately, healthcare has become extremely politicized. So we've seen this with other areas like the IRA. We have a handful of drugs where we've seen prices being negotiated, but the other impact of the IRA was the limit on member out of pocket at $2,000, and that shifted more cost to the pharmaceutical industry. And what we've seen there is actually more closed formularies and worse access. And we've had PDPs exit the market, and we're anticipating commercial prices to go up to offset what happens on the Medicare side. So again, it's unintended consequences. We would love to see prices go down. I think that's helpful, but I don't anticipate really seeing that happen. But I would say, despite my comments, we have to try something, because trends in this country are out of control. We see a doubling in drug costs in the U.S. about every 4 years if you go back over the last couple of decades. It's putting a lot of pressure on people who are paying for insurance. So health plans, employer groups, and ultimately impacts our members. And so unfortunately, I think we're really close to what I call an affordability and accessibility cliff. So anyway, long answer there, but hopefully we see some decrease in pricing, but I also anticipate other unintended consequences, because this really is being run in parallel to a lot of other things that are being worked on right now, including the things I mentioned, the IRA, 340B, and how that's going to impact this. There's a lot of things going on, and it's complicated. And so addressing one thing and not looking at healthcare holistically historically has led to increases in prices, not decreases in prices.
Thanks. Harold, what are your initial thoughts on the MFN?
Well, we think here in Germany, we pay already the highest prices, drug prices in Europe. And when now some companies say we have to pay even higher prices, like the CEO of Novartis, Narasimhan, he said that the prices in Switzerland and in Germany are far too low. The payers say that's unbelievable. We're not willing to pay even higher prices. Yeah? That is very difficult to explain to the population, to politicians. And I think that politicians then would say, okay, just withdraw from the market. So if you have the 42nd TNF inhibitor, it's not a big issue, or some interleukins. Of course, when you have a drug with no other competitors, then it's could be a problem. But I think we are going to take that risk, that we would not have any longer access to all drugs. That is maybe also unique here in Germany. Currently, we reimburse every drug immediately, automatically, 1 hour after EMA approval, no restrictions, and that might change. So our new Minister of Health said she wants to reduce anyway the catalog of reimbursable services, not just drugs, services. And then she would say, okay, then we have to also apply to drugs that we would no longer reimburse every drug. But it's unlikely that we are willing to pay higher prices here in Germany.
And James, as an economist from the UK perspective, what do you see in the MFN?
Well, I mean, I can answer as an economist first, I suppose. I find it very challenging looking over the Atlantic and looking at the, and I'll pick my words carefully, economic naivety of the people that you have in charge. It's very clear that this is going to make very little difference to the price of drugs in America. And the reason why that's very clear is because look how the rest of the world is reacting, and look at the fact that people are saying, what's this going to do with the prices everywhere else, not what's it going to do to the prices in the US. So what does that mean? Well, so for America, it means they're going to have to find another strategy. But I appreciate that the drug prices in America are a problem, just the solutions they've come up with are just not going to work. Because what has worked in the rest of the world to keep drug prices down is politically unpalatable, I think, in America. And what's worked, of course, is basically having monopoly purchases of drugs for most people, i.e. a centralised healthcare system that's doing the centralised purchasing. And then you can properly negotiate with a monopoly provider of a good. In America, you can't do that when you've got loads of individual providers all negotiating separately. Yes, drug prices have spiralled everywhere, not just in the US, they've spiralled in the UK too, but we have mechanisms where we can keep them down. And we don't just have mechanisms in terms of the price, we have mechanisms where we're also hitting the profits of the companies so they can't make too much money off the branded drugs that they're selling into the NHS. So what difference will it make to the US? Very little. What difference will it make to the UK? I think that's a very open question at the moment. I can see we're going to be very much like Germany, where we're going to say if the drug manufacturers are going to say we're going to put the prices up, we have our mechanisms both to measure the cost effectiveness of a drug and say nope, not at that price, or say no. And actually we're getting quite a mature population now that I think have had enough news stories where drugs have had no's to them and people understand it's because the NHS afford it because these drugs are overpriced. And so I think there's more of a political will to say no here to drugs and that to be accepted than they might be in other places where they've not been saying no to drugs, like Germany. You can have anything, it's all on the table. Whereas here we have said no to things. So I think we're in a stronger position there. Or we could just say, yeah, you can have whatever price you like, but we're just going to claw all your profits back if you try to sell into the NHS. In which case, either way, the company still might say, well, we're not going to supply into the NHS, and the NHS will go, well, it's on you then. And I think people will blame the pharma companies and not the politicians.
Yeah. Going back to you, Harold, with that, the overwhelming majority of prices, both at list and net, are visible for everybody to see from a German perspective. Do you think this is something that changes following the US changing something or more companies exiting reimbursed markets in Germany? Because I know there's a number of times when the negotiated price is settled upon, companies pull the market products from the market. So how do you see that factoring in with the confidential pricing?
Well, I expect to see more confidential discounts here in Germany. That possibility, by the way, was introduced already 2 years ago, so long before the MFN, independent of the MFN. But it was never used. That's interesting. No? So no company used it. And the first company that used it was Eli Lilly for Mounjaro. And that had a US background. And well, we have that door open. You can use it. You can have confidential discounts. And I think that will now happen next year, especially. But I think it's not the long solution, because the question is always how confidential can be any discount. Maybe US payers or the government can't find out what the true price is. That would be my fear here.
Can I just interject there? Because we have confidential prices in the UK, and we've had them for a number of years. It's almost every drug that goes through NICE has a confidential price, and the discount is eye-watering sometimes. 80-90% is not uncommon to get a drug over the line. I think you raised Mounjaro, and that raises a very interesting point about what the price is that will go into the MFN calculation. With Mounjaro now, they have made the headlines because they've increased the price in the UK by 170% overnight for private buyers. But the price to the NHS will remain the same. And the price to the NHS is about £100, and the price into the private market goes up to £300, £330. So which price is it going to be? Now, the Mounjaro confidential price isn't that confidential into the NHS. Everybody seems to know what it is. But lots of the prices are actually genuinely confidential. And it's very interesting when we get submissions, you can see the company doing the submission is trying to guess what the confidential discount price is for their comparator. And sometimes they get close and sometimes they're miles away. So they don't know, but there'd be nothing stopping the US government saying, you tell us what your confidential discounts are. And that then would pose a big problem for NICE. If they don't do that, it won't make any difference to the UK, because most of our drugs anyway have got these confidential discounts, and if they remain confidential, who cares? But I can't see the US government being happy with that, and they're going to demand to know what these confidential discounts are.
Yeah. Jeff, how have you seen that with the rollout of the IRA negotiations? So with that, there's been a place where Medicare for the first time centralized negotiation processes for those drugs. How did that change your business model, or at least around those products?
Yeah. It hasn't really yet. We're still, I think, trying to figure this out because it took a while, and there's still a lot of questions around how those rebates flow through the system and who collects them. It's potentially putting a lot of pressure on retail pharmacies. But like I mentioned earlier, we don't have similar pricing on or different pricing on the same NDC. And so, again, what we're seeing is probably an increase on the commercial side. And we've already seen this as an offshoot of the IRA. We've seen PDPs exit the market, and we've seen more closed formularies, so more focus on generics and other things. And so the unintended consequence is less access for Medicaid or Medicare beneficiaries. So it's pushing the balloon. So yeah, for a handful of drugs, great, but costs are going up elsewhere, and again, you have to kind of make up for that.
So if MFN goes forward, do you think more PDPs exit the market?
Well, it'll be interesting to see, because I think it's multifactorial. It's IRA, it's 340B, it's a bunch of other things that are going on here, in addition to just, drug trends around GLP-1s. We've got, a lot of questions around tariffs and what that actually is going to result in. So I think there is going to be more consolidation in the Medicare space, which again potentially lowers access for patients.
Okay. Now, critics have argued, and certainly the pharmaceutical industry has taken the point of view that lower prices dampen pharmaceutical innovation, and that the proponents say innovation must also serve affordability. How do you guys see balancing those forces? How do you see them balanced in your countries today, and how do you see that changing over time? I can start with Harold this time.
Well, as I said already, we are willing to pay high prices, and we did pay high prices over the last 20, 30 years. But we would rather say you should refer to other countries that are not paying such high prices as we here in Germany or in Switzerland. The interesting thing is more than 40 countries in the world refer to the German prices over the last 20 years. And that turned out never to be a problem. Just now, when the US wants to join and refers to the German price, then we have a problem. Then the company says, well, you should pay more in Germany. So I think you should look at the whole market. 85 million inhabitants is a high number, but it's not the whole European market. And that should also be a perspective, to look at the number of patients, not just at the price in one country.
And with regards to access to new technologies, right, which is really what innovation is supposed to lead to, have James and Harold, have you guys seen a reduction in access to new technologies? Have you felt like it's, from your perspective, it's harmed anybody? What have you seen?
No, not at all. As I said, we reimburse from the first hour on any drug. Immediate reimbursement in Germany can not be faster. So we reimburse not just immediately, but always 100% of the label. Not like in England, where the NICE Institute loves to carve out tiny subgroups and would just reimburse these. It's always 100% of the label, immediate reimbursement, and 6 months free pricing. Well, what more do you want? Can be easier.
Well, I would say, what more do you want as a pharmaceutical company? Because that sounds wonderful. But
Yeah, right.
as a payer, that sounds absolutely appalling. As somebody who reviews the submissions, I can tell you why we make those recommendations, because some drugs are hideously marginally effective or ineffective for some subgroups of patients, and they cost an awful lot of money, and you're giving somebody a drug that does very little compared to a much cheaper drug that does essentially the same. So we already make those optimized recommendations. We already say no to some drugs, and when we do say no, we quite often end up getting yeses after the companies realise that the true value proposition of their drug is not commensurate with the price that they want to charge. But we're transparent and open about how we're doing that, so everybody knows how to play the game. And I think the problem with there are several problems with the German systems, and some are very, very good. You know, some things that are better, but I think everything seems to be a bit more behind closed doors, perhaps, than it is in the UK system, where everybody can see the evidence and can see how effective it is. Just as a very quick aside, I'm minded to have been sat in one committee meeting, and a member of the public was there. They saw me on the train afterwards. It was a no, and they had the condition. They had the condition that this drug was for. Young man, and he said to me, "That should be a no." He said, "I've got the disease, but I can see that drug does very, very little and costs a fortune." So, you know, people can be grown up and have these grown up conversations if you're willing to share the information with them.
Harold, do you have anything to add, or Jeff, anything to add to that? Go ahead.
Well,
Jeff.
I would say I think we've already seen a significant fundamental shift in R&D over the last decade. When I started, my career 25 years ago, we were spending the most money on drugs like PPIs and statins and things like that. And if you look at pipelines now, it's not primary care. It's not things like antibiotics. We see. We've been saying for years that there's no incentive for a pharmaceutical company to look at an antibiotic because they're inexpensive. And so that puts, the population at risk. So, the cynicism that we have is that in this country, drugs are priced based off of prevalence and what the market will bear. And James alluded to this. It's not on value. We don't have the ability to price on value here. And so, I get asked all of the time, well, I have a drug that's only estimated to have a few thousand patients on it. So can I charge $1 million because somebody else got $1 million for an unrelated disease state, but it was also rare? So the average cost of an oncology launch in last year was about $300,000 in this country. And 4 years ago, it was $150,000. So in 4 years, we've seen a doubling in the price of a new oncology drug. So I would say that it's already shifted. And so, payers get knocked a lot for lack of transparency, but I think there's a lack of transparency from other stakeholders, including how drugs are, what the cost of a drug is to get it to market. If we had more transparency across the system, we would love to pay for value and pay for outcomes. That's not what we pay for in this country. We pay for prevalence and what the market will bear.
I realise, Bill, I've not actually answered your question, so I'll try to answer it quickly. I think it breaks down into there's three separate points to your question, really. I think the first is one about equity, and equity of who's funding research into new treatments and how is that distributed across the world. Why the US cares about that, I'm not entirely sure. But arguably, yes, the rest of the world is maybe having a bit of a free ride in terms of the amount of money that's gone into research and the profitability of companies predominantly coming from the US. So fair enough. I think the second point is about whether innovation will be reduced because of MFN or increased because of MFN. It will be reduced. It will be reduced if the only thing that's driving innovation is profitability, because companies will become less profitable because they won't be selling in as many markets. So it will hit innovation that way. I suppose the third point would then be is, as the system is set up, are we getting any innovation? And I would say no. I think if you look at a lot of the major breakthroughs we've had in medicine over the past 100 years, they haven't primarily been driven by vast billions being spent on other drug. They've been largely by chance or incidental findings or from universities, or there are other ways that innovation will arise other than the drive for profitability from pharma companies. So, yeah.
Okay. And I brought up at the beginning. Go ahead, Nekshan.
Yeah, I only wanted to add to that because we've seen so much in the news recently about investment being pulled out of the UK as well, with AstraZeneca and then MSD. And so the world we live in right now, it is what it is in terms of if they see revenues decrease, people lose jobs, innovation is gone, investments are driven to different sectors, right? So given that's the world we live in, as a patient and as a consumer of healthcare, isn't that a concern, the consequences of MFN?
No, because your question is, it's a bit of a straw man argument. So if they pull it out of, sorry, apologies. If they pull investment out of the UK, then it will go somewhere else. Now, as a UK healthcare consumer, why am I bothered whether the R&D is done in the UK or China or anywhere else? I just want access to medical treatments that presumably will prolong my life or increase my quality of life. Whether that research is done in the UK or not is irrelevant. It would, if they're pulling out, it's pulling out to do it somewhere else. It's not because they're saying the UK is not a profitable market. They may be doing it to try to punish the government politically, to say we're taking your jobs away, but in terms of development of those drugs, that development will happen somewhere.
We have,
Yeah, I think I would just,
Go
ahead, Jeff.
add on to that,
Please.
yeah, I agree with that. I don't, we see data and research being done, outside the US all the time. I don't think that's the question, but I am very, very concerned about access and affordability. I mean, those are soapbox things we talk about all the time because, premiums go up exponentially, driven by costs. And if we list continue, you see high deductible plans. We're really heading towards catastrophic coverage in this country. But, not to get political, but if you look at unfunded debt and, all of the other programs, it's getting to the point where no matter what we do, patients are not going to have general broad access to things, and that is concerning.
And you brought up the 340B changes, Jeff, that are there, and let's just talk a little bit there. And for my colleagues, James and Harold, if you don't know 340B, it is an offshoot of the Medicaid program that is for outpatient provision of drugs through other systems. And so the Medicaid price extends there. Jeff, when you think about the first round of Most Favored Nation, you think about he's targeting getting these prices into Medicaid today. I know you've worked on the managed Medicaid side before, and you've seen some of the supplementals that have come in the CPI-based pricing. How much of a benefit do you think that'll actually be into Medicaid, and what does it do to someone like Medi-Cal, where they have massive negotiating power today?
Right. If you look at Medicaid, some drugs are already basically 100% discounted to states because of price increases and how the mechanisms work there. So again, I think messing around with this is probably just, and I say messing around, it probably puts more pressure on states, and we're going to see more of this, and we're already starting to see more of it. Again, closed formularies and carve outs and other things. But 340B, I think, was one of the acknowledged unknowns as part of the MFN, and because so one of the questions is, as we negotiate prices through the FMN, are the 340B discounts carved out of that, not factored in? So again, I don't think that has been explained, at least from what I've seen. But 340B is a huge, another huge hot topic right now because it is being used in a way that it wasn't intended. So, pharmaceutical companies are looking at it. There's probably going to be some changes. My fear and concern, though, again, like I said earlier, unintended consequences is we have hospitals that are in business because of 340B pricing. And so if things change, we will see hospitals, and it just exacerbates what I talked about earlier around accessibility and affordability and all of those types of things. So if you touch these programs and change them without looking at it from a big picture, it usually has unintended negative consequences. I don't know if we can look at it from a big picture realistically.
And Harold, you brought up other nations could pay more, that concept. And I think we're literally sitting in a place where we all agree that Germany does pay the highest prices in Europe, and that the UK probably pay some of the lowest prices in Europe, not counting maybe Greece and some other countries like that with the negotiation. Let's talk about that disparity a little bit and how you see both an MFN policy trying to deal with that, as well as you guys. I'm looking at you, James and Harold, how you wrestle with the difference between your countries when you're talking about manufacturers. Harold, you brought it up, threatening to move away from your market. Well, we don't need you, right? Where do you see this kind of going if that happens? Because you're right, you pay the highest price, others pay less than that. What do you see?
Well, I mean, I would expect even higher drug prices here in Germany. But there's a point where we also can say no more in Germany, where we would say we cannot afford much higher drug prices. And then the question is, what will happen? When the manufacturer says no confidential discounts, then the last step is withdrawal from the German market. And in the past, 16 years, that happened just a very few times. And most companies withdraw with drugs that received a no added benefit rating. That was easy to justify for a German payer. Say, dear patient, there was no additional benefit. And there are very few examples where the drug came in an empty market like Translana for a neurodegenerative disease and received a positive rating. And the manufacturer nevertheless said, we withdraw from the German market. But Translana is a good example. What happened then? We later from Austria. The Austrian payers offered a lower price. Here, interestingly, the manufacturer said, okay, we accept it. And then we nowadays get it even cheaper than earlier. But you see, it's easy here in the EU to import from other countries drugs. So when the manufacturer wants to hurt the German market, they have to withdraw from whole Europe. And that's a big market. That is then interesting to see whether this is then still a good business idea for the manufacturer.
James, how do you see reconciling the delta between prices and the delta between country behavior in this list of like countries, right? Where we're putting all of you together to say, hey, we can get your prices here. What do you see?
Yeah, I mean, I think it's fascinating you brought up about parallel trade. I produced a report on the parallel trade in pharmaceuticals across the EU about 20 years ago. And at the time, we predicted that there would be more convergence in price over time, surely, because everybody was importing cheap from Southern Europe into Northern Europe. And it hasn't really happened in the sense that the companies haven't set their prices all to be, okay, we're just going to have one EU price and then be done with this. And we'll set it to be the highest. They have accepted that there'll be lower prices on the part of Europe, and if the other countries want to import in, then they will do. And perhaps it's the lesson there that the companies have an incentive to do that now to try to maximise profits, ignoring MFN. Across Europe, they could just have one standard price, knowing that parallel importation goes on. And yet they don't. And they don't because they're profit maximising. So there must be something in there that's stopping them doing it that I can't quite see. Whilst ever there's a loophole that will allow them to have differential pricing across Europe, they will maintain differential pricing across Europe. If MFN comes in really strongly and they say, no, we're just going to, the US government says it's going to be the lowest price in whatever basket of countries we're talking about, then if the companies really cannot hide what the price is, having confidential discounts and things, there will surely be just one price in all those countries that will be basically the American price. Well, by default, it will be the American price. But and then whether the individual countries decide they're going to reimburse or not will be entirely up to them. But I can't see any EU country or Great Britain or indeed Australia and Japan, where else they might be looking, accepting the US price for almost any pharmaceutical. Just not cost effective. Or affordable. Forget about cost effective.
Okay. And Jeff, as the working for, and you do want to make it political, but I'll bring it in political. There's been some targeting by the administration for the middlemen, right? Both with direct to patient type of moves, as well as the PBMs and others don't pass through everything they should, and concepts there. How do you see that middleman targeting playing out as a part of MFN or being carved out separately? What do you see there?
It's part of and separate. So right there's MF, like we said, there's MFN, there's 340B, there's tariffs, there's the PBM legislation or payer legislation. It's all, again, it's not coming at it collectively and kind of looking at how we address the system. These are all kind of separate things, and they don't work very well together. As a quote unquote middleman, it's interesting because are there things that the industry does that could be better? Absolutely. But it's well documented that what we do actually drives in better outcomes and lowers costs. So it's a little, I think, unfair. And by targeting just PBMs and health plans, I think it assumes that the other stakeholders in the chain are aligned. And I don't believe they are. One of the other soapbox items I have, and I say this all the time, is misaligned incentives. And you can look at brokers and consultants, you can look at providers, you can go on down the list, and they're not aligned as well. And to use an example, so we always get negative remarks and comments based on rebates and rebate retention. PBMs don't retain a lot of the rebate. Most of that is passed on anyway. It's just maybe not fully transparent. But the reason that we do, one of the main reasons that we do go after rebates is because we have to provide rebate guarantees to our clients. And that's really mandatory because of the consultant broker requirement. So if that goes away, then all you're going to see is now a change in admin fees and service fees and things like that. So there'll be more transparency around it, but I don't think costs will go down. I just think costs will be shifted somewhere else. And so, that anyway, again, a long answer to your question, but yeah, that we will continue to be a target. There are some things that need to be cleaned up, but credit is not given for all of the good things they do. And I don't think that actually is going to decrease costs. And because we don't get credit for a lot of the good things that payers do, which is driving outcomes and, any number of other, and providing access and focusing on social determinants of health and equities and everything else. And so, again, we got to get out of our silos. We have to align incentives and we have to de-silo the system. And unfortunately, I don't know how that gets done.
All right. So, wow, if you're watching this at this point, you've now realized just how different the German, the US, and the UK health systems are in how we cover and pay for meds and think it through. I have you three really smart gentlemen with lots of experience and a lot of background. So let's talk about this. If we agree with the premise that the US price is too high and the German price is the highest and there's others that are lower, what do we do if we don't do something like MFN? What do we do? What are the alternatives here? What do you see as potential solutions globally, at home, whatever you want to say, just what's out there for next steps?
Well, I would say I would give you a naive answer, and I'll start. And it goes back to, again, some of the soapbox items I've mentioned is we need to de-silo and we need to figure out how to share risk. So that's probably a naive answer, but value-based pricing instead of prevalence-based pricing and risk-based agreements with providers and having pharmaceutical companies in that. So we can talk about outcome-based contracts that we've had. They don't work. They're not real outcome-based contracts. And we have some risk-based agreements with providers, but not most. And there's really no incentive for them to enter that. So until we actually share risk and have more joint decision making, and we stay in our silos, I don't know if this is fixable. There's my cynical answer.
Okay.
I would agree. I mean, I think the solution is there because the solution is in the rest of the world. Your premise was that the US pays too much almost and we pay too little. I'm not entirely sure that's true. The US probably pays too much, but do we pay too little? We pay the value for the drug. So I'd argue, nope, we've established what the value will be and that's what we want to pay. I think that the problem is the solution is not politically palatable in the US. The solution is a centralized purchaser of medicines. And you need that centralized purchaser, or at least a centralized decision maker who's saying this is what the price will be, even if you remain a largely private market, because you have a monopoly provider. I mean, it's just economics 101. You have a monopoly provider, they will screw you unless you're a monopsony purchaser. You need that counterbalance. And until you go there, they'll be round and round in circles and you'll never get anywhere.
Harold?
Well, we introduced 15 years ago value-based pricing in Germany. Now you can say that was not enough. We should pay 100% US surcharge. But that is difficult to justify for politicians, for patients. And therefore, I think the short-term solution here in Germany would be the confidential discounts. My feeling is just that this is not the long-term solution. But for the next 2 years, maybe that could help the US government. And then let's see, but we are not changing our value-based pricing system. That is highly unlikely.
I just think that the confidential-based pricing will not help the US system unless the US system, because the US goal is not prices in Europe. The US goal is reducing prices in the US, of course. And so that only works if their confidential prices are shared with the US, which the US could well force them to do. But I was thinking, just as an aside, I thought there is an alternative that could happen, that could maintain the lower prices in Europe and the higher prices in the US and accessing both. And that could be the manufacturers could do what they do now when patents start to expire. They just come up with a different formulation with a slightly different name and different mode of action to extend the patent. You could say, okay, we're going to have a subcute version in the EU and we're going to have an IV version in the US, and they are different drugs. So whatever legislation is drawn up is going to have to be so tight to make sure you're comparing like with like, and to stop the pharma companies gaming the system, if you like, by just modifying the drugs ever so slightly so they're not the same thing, so they don't enter the MFN basket.
Yeah, that's a great point. What being touched on is, healthcare has become super politicized. And so I think there's still some questions on if this is even legal and what the ability is to execute on some of these things. But then you get into lawsuits and you get into negotiations and everything else. And so, even if you have something that you tend to lose the teeth of it anyway. So, we're talking about this. I don't even think we've answered the question is if these things are even executable.
I don't think that's a question we can answer, or should, if I'm being completely honest. Let someone else opine on that and see if it comes through. And back to the point we talked about, Jeff, that even if it came into being, just like with IRA, how it actually rolls out and what the actual rules are, IRA is now significantly baked, but still you don't know exactly where that money comes from, who's responsible for it. So it's a place where, it's still a problem. One of the things that I wrote an article on not too long ago was about drugs are not the only thing that are higher priced in the United States. In fact, a lot of goods and services are higher priced. I mean, that's why we have medical touristry. You have medical tourism in from the UK going other places to get even cheaper than you could get it in the UK, right? So it happens everywhere. Why do you think, and pharmaceuticals are not the biggest bucket in the spend on healthcare by any stretch of the imagination. So why do you guys think we keep coming back to this? And I'll just invite this to be your closing statements as well.
I would say because it's the easiest thing to see. So drugs account for what, 20% of the overall healthcare, something like that.
Yep.
But it's the most visible and it's the easiest to see because you have claim-based data, you have point of sale adjudication. It's clear. Under medical, you don't have point of sale adjudication. You have prices are completely different. On pharmacy, it's WAC minus rebate. On medical, it's fee schedule based. It's ASP based. There's who knows, and claims come in months after something's done. There's just we talk about transparency. I'm not talking about the same definition of transparency, but medical is even less transparent than what goes on under the pharmacy side. So I don't even think anybody even knows how to address medical because at least pharmacy is somewhat clear.
Yeah.
I would say in the UK, I think it's 10% of the NHS budget goes on drugs. 90% is on other healthcare. I think it isn't actually a big issue because people don't pay for the drugs privately here. Other than interesting are the weight loss drugs, and the weight loss drugs are a really interesting little case study of something very different that's happened in the UK, where people now in large numbers are privately paying for an expensive drug. But up until that, people just see you might have a small prescription fee of £7 or £10, whatever it is, but it doesn't reflect the cost of your drug. And when you go into hospital, your drugs cost nothing. So I don't think drugs are at all, drug prices are on the political radar for anybody really at the moment.
Harold, final words? Anything?
Well, the biggest cost driver in Germany is the hospital sector, of course. But here we're facing also the introduction of a entirely new DRG system. So you see, you cannot say, oh, it's just a drug market. No, we also focus on other cost driver.
So I want to thank you guys for your time this afternoon and this morning. I greatly appreciate it. This debate, I think, continues to identify tensions between global markets, right? It just shows differences that we have and commonalities that we have as we seek to reconcile a new future. And I greatly appreciate your thoughts and times as we try to reconcile, right, a market that I think you all said, well, how do we get there from here? We're not sure. So I really appreciate that and your candor today. And I just want to thank you all for your time and wish you the best week possible.
Thank you.
Thank you. My pleasure.